let us discuss different kind of case studies. So this is the first case. A 27-year-old female presented with cough with expectoration, fever, anorexia since maybe 1 month. After different examination and investigation, her sputum AFB gram ZN scan report is grade +2. So it is Mycobacterium TB infection. And sputum gene expert is MTB detected and rifampicin sensitive. But with the same time, we have also sent the report to WGS and see what is the report. It is the same as gene expert. But what is the advantage of this report? On the left side, you can see the different names of the drugs. And on the right side image with the green round, you can see the sensitivity report. So there is no red mark. So it represents that each and every drug for this patient is sensitive for his or for her tuberculosis infection. So we all know that for the sensitive report, we have to just start a drug sensitivity, which is HRZE for 2 months, followed by HRE for next 4 months. So see, we have started treatment and patient is improved. And 63-year-old male diabetic patient presented with dry cough, fever, and weight loss since 2 months. His sputum AFP report is negative. But on the radiological part, there are lots of lower zone consolidation with cavity presented in his X-ray and CT scan also. So I have directed the patient to sputum gene expert, and the report is Mycobacterium TB detected and rifampicin sensitive. Here is the trap. So as per the protocol, we have sent the patient sputum to LPA also, and we get that rifampicin and isoniazid both are resistant. But duration time to get the LPA report is 30 days. But with the help of WGS, you can see that on the left side, 5 different drugs named rifampicin, isoniazid, ethambutol, pyrazinamide, and also streptomycin, which are not using nowadays, injectable streptomycin, but each and every drug is resistant. So first, with the report of gene expert, we have started. Gene expert report is MTB detected and rifampicin resistant. So we have directed patient to shorter oral bedaquiline regimen. But after getting a WGS report, because WGS report is taking time off for this patient is 28 days only, because in his sputum they have to cultivate, like culture was done before the WGS was done, so it will take time to grow the bacilli. So plus culture time plus WGS, so cumulative it will take 28 days, and we can get the report of HRZES. Each and every drug is resistant. So after the end of 28th day, we have directed patient to all oral longer. So you can see that 28 days and 30 days. So 2 days gap. Just early start with the WGS report. In the next patient, it is the same like the previous one. 19-year-old male patient, a known case of chronic kidney disease, presented with dry cough, fever, anorexia since 15 days. Sputum AFP is negative. Gene expert is suggestive of MTB not detected. But with the radiological evidence and bronchoscopy, we have sent the BAL gene expert with bronchoalveolar lavage, and we can get the report of MTB detected with rifampicin resistance. So here is the trap is with the WGS, we have directed BAL to gene expert and BAL to WGS. So here is the report: rifampicin, isoniazid, ethambutol, and streptomycin with moxifloxacin, ofloxacin, moxifloxacin, and getafloxacin. Each and every drug of FQ which are using in the TB treatment is resistance. So only pyrazinamide and rest of the drugs are sensitive, which is mentioned in the circle that red part is resistance and green part is sensitive. So we can modify his treatment with, and the plus point is we can get the report within 18 days only. If you are doing culture DST, it will take time, maybe 45 days. So as per the protocol, with the resistance report, I have started the treatment as a all oral longer. Yes, a 33-year-old male patient with the chief complaint of cough, with expectoration, anorexia, and weight loss since 3 months. His sputum is +3. Gene expert is suggestive of Mycobacterium TB detected with rifampicin sensitive. So here is the WGS report, and it is showing that moxifloxacin resistance. So I think we all see the patient that either GP level or MD level or few other pulmonologists also adding levofloxacin to the non-responder. If your HRZES, each and everyone is sensitive, but as per the history and as per the previous clinical approach, we are empirically adding FQ to few of the patient, but this is the trap that the patient is completely drug sensitive tuberculosis. So there is no change in treatment. The investigation duration time is only 10 days of WGS, and the treatment is drug sensitivity because there is no resistance of HRZ. So there is no need to change your regimen. Next one is very interesting. A 27-year-old female patient, she is suffering from pulmonary TB with maybe post-TB bronchiectasis changes. And she is on treatment for pulmonary TB since 5 months. And the positive report with the positive report of sputum AFP +2 before 5 months. So some general practitioners have started the treatment of drug-sensitive tuberculosis. As I have previously mentioned that few of the doctors will start levofloxacin to the patient if he or she can't see the radiological changes or the clinical improvement is not there. So same in this patient, the doctor has started drug-sensitive TB treatment with levofloxacin after 2 months of radiological not improvement in the patient. She had also history of childhood tuberculosis, but with the 5 months of treatment, when she is presenting to me, there is no symptom improvement since 5 months. Cough with expectoration, hemoptysis, and fever is same as it is. And in the history part, I have seen that within the last 1 year, total 3 different gene expert was done, and each and every one is Mycobacterium TB not detected. One doctor have also investigated for sputum culture, and the report was NTB detected, and each and every drug is sensitive. Her fungal culture was also done, which was no growth in the fungal culture. So I have done the WGS report to this patient, and see the report is the sample has significant bacterial DNA. So this is the confirm that patient is having Mycobacterium TB infection. The second line is Mycobacterium TB resistance is detected with incomplete DST because rifampicin resistance was detected low. So you also know that in the gene expert report, few of the report are with same mention at Mycobacterium TB low detection and rifampicin indeterminate. This is the same as a gene expert report. in the bold line, you can see that failed the quality control of genome sequence in the analysis. And second part is multiple other organisms are also detected. And they are aerobic gram-negative bacteria of Campylobacteria, possibly nosocomial origin, have been found. So this is the trend that patient might be having drug-resistant tuberculosis, but as per the history, she is on levofloxacin since 3 to 4 months. I have started directly patient to all over longer, and within the 15 to 20 days, each and every symptoms are gone. So WGS will help you in this side also. And for gram-negative bacteria, I have sent the patient for sputum CS, and we can get the report of all gram-negative bacilli, and we have started the treatment as per the sensitivity from sputum CS. So it may possible that patient is having pulmonary TB with secondary bacterial infection in the bronchiectasis. A 22-year-old male with the recurrent right cervical plus bilateral axillary plus inguinal lymphadenopathy. And he's on treatment of TB drug since 1 year as an empirical, because there is no confirmed report of tuberculosis. The treatment started by a physician with the evidence of sonography. FNAC was done, but it was inconclusive before a year. Then I have done a help of ENT lymph node excision from the axillary part, and send the whole lymph node to the cytology and to the WGS. So specifically, this is the interesting part, that cytology suggests of lymphoma. It is not a tuberculosis. It is Hodgkin's lymphoma. And see, the conclusion is there that WGS sending this report that specimen is a lymph node. There is no AFB and no growth of Mycobacterium species after 6 weeks of incubation. So now your main question is why you are promoting WGS. So this is the answer. That TGS, which is tuberculosis genomic sequencing. Second one is culture DST. Third one is Sabina. And fourth one is LPA. So how many drugs are coverage by different investigations? So WGS is taking a coverage of 18 antibiotics. Culture DST is taking only 13 to 15 antibiotics. Sabina is only giving you a report of rifampicin. And LPA, I have mentioned, there are 4 different drugs. The turnover time, it is only 12 days only in WGS. If you are doing culture DST, you can get the report within 2 to 8 weeks. In seminar, it will take only 2 hours. This is mentioned, it is wrong. It is only 2 hours. And in LPA, it is only take time of 3 to 4 days. We can compare cost-wise also. The WGS is having, the main part is, if you are doing WGS by Thyrocare, then it is 3 to 5,000. But the main cost of WGS is 15,000. Same as a DST. Cibinat is having only 2,000 and LPA is 4,000. So if you are approaching a patient from Cibinat 2,000, then LPA 4,000, then culture DST 15,000. So the cumulative amount is higher than the WGS. And with the help of Thyrocare, we can just get a report within 3 to 5,000 only. And main advantage, the strain of identification of mixed infection, you can get that report also. So these are my take-home messages, that the TGS is a single test to give a complete genomic analysis of Mycobacterium TB based on WGS. It gives simple and precise result with the advantage of rapid turnover time, which is only 12 days. And you can start treatment to the patient in a specific manner, like patient-based approach. So it is helpful